The choice of frontline agent for multiple myeloma is driven by our clinical trials. We have had a number of trials over the years that have been done in older patients. The treatment for an elderly patient with multiple myeloma 20 years ago used to be melphalan and prednisone. We went through a series of trials that looked at a 3-drug regimen of melphalan, prednisone with thalidomide that showed that there was certainly improvement in progression-free survival and some improvement in overall survival of these patients. But the fact is that thalidomide was a difficult drug for older patients to tolerate. We then had trials that looked at 3-drug regimens of melphalan, prednisone with lenalidomide and compared them to melphalan, prednisone with thalidomide and showed that the results were fairly equivalent. However, our field has always wanted to try to move away from the use of melphalan in frontline therapy. The drug has got some toxicities that may not be the best for older individuals. Also, the drug has somewhat erratic and delayed responses. So, the first trial that was published in the New England Journal of Medicine a few years ago looked at using lenalidomide and dexamethasone and comparing it to a standard of melphalan, prednisone and thalidomide. And this trial showed that lenalidomide and dexamethasone followed by long-term lenalidomide maintenance improved progression-free survival and the depth of response. So, at least based on the trial, the management of this patient was certainly appropriate. It is based on evidence-based medicine. Now, in the future, we are going to have more trials that may change this standard. There are several trials that are pending at this time that are looking at 3-drug combinations and comparing them to the Revlimid dexamethasone standard. These include trials looking at ixazomib with Revlimid and dexamethasone, elotuzumab with Revlimid and dexamethasone, and also a trial looking at daratumumab with lenalidomide and dexamethasone. These may certainly change the standard of care in the years to come. More recently, we actually had the approval of a 3-drug regimen of Velcade with melphalan, prednisone and daratumumab by the FDA for frontline use. Once again, we will have to see how that leads to a change in the therapeutic landscape. As I have stated, the use of melphalan in frontline therapy is something that we wanted to move away from. And certainly people are wanting to use our novel drugs in frontline, but this may not be the best mix for the patient. There are obviously a lot of factors we consider when we decide on how to treat a patient frontline. Paramount, I think, still remains whether a patient is transplant eligible or not. For those who are transplant eligible, we try to avoid the use of melphalan based regimens certainly. For this particular patient, the current standard of care, at least based on randomized trials, is lenalidomide and dexamethasone. We know that the 3-drug combinations that we have now got in the second line and beyond setting seem to provide very good results even for patients with adverse risk chromosomal features. However, we have no data in the frontline setting at this time. So, I think that in the future our standards may change, and the information from chromosomal features and FISH testing may inform our decision regarding choice of therapy, especially if our choice of therapeutic options multiplies. But at this point, I think that the major use of the chromosome and FISH information is for planning post induction phase of therapy, especially for the transplant eligible population.